Okay, everybody, welcome at this ERKNet ERA educational webinar. My name is Tom Nijnhuis. I'm an adult nephrologist from the Radboud University Medical Center in Nijmegen in the Netherlands. And our speaker of today, and I will be your moderator today, excuse me. And our speaker of today will be Dr. Aude Servais, who is a senior nephrologist at the Department of Adult Nephrology at Necker Hospital, Paris Descartes University in France. And she's a referent in adult nephrology at the Reference Center for Child and Adult Hereditary Renal Diseases and in the Reference Center for Inherited Metabolic Disorders at Necker. She's also the vice chair of the ERKNet Working Group of Metabolic and Stone Disorders, and her research interests include the management of cystinosis, genetics of focal segmental glomerulosclerosis and Alport syndrome, cystinuria, and C3 glomerulopathy. Dr. Servais has coordinated the European cystinuria clinical practice recommendation, which has been published in Kidney International in 2021, and has authored more than 100 research articles in peer-reviewed journals. And today, she will educate us on the Adenine Phosphoribosyltransferase Deficiency, which we can abbreviate by PRT Deficiency as an underdiagnosed cause of renal failure. But before I give Aude the floor, I would like to ask you all to type in your questions in the question box for the discussion afterwards. You can also do that during the webinar. Just be sure when you do that during the webinar that it's clear to us what the question actually refers to. So if you punch in, is that also the case in etc., then we afterwards will not remember anymore what that actually refers to. So please be clear in your questions, but also punch in as much questions as you can. So with this, I would like to give the floor to Aude. Aude, the floor is yours.
Thank you very much, Tom. Good afternoon. We will speak today about PRT deficiency, which is, as you said, an undiagnosed cause of renal failure. This is in the family of hereditary nephrolithiasis, which represent 2% of adult stones, but 10 to 20% of children's stones. It is very often overlooked, but it carries a very high burden of stone recurrence, chronic kidney disease, and potentially leading to end-stage renal disease, as we will see here today. And I think that awareness of nephrologists could decrease the delay to diagnosis and improve outcome for these patients. We will start with a case report of a patient who had his first nephrology consult for chronic kidney disease at 52 years of age. He has a past history of stone disease starting at 32 years of age. He already had 3 extracorporeal shockwave lithotripsies, 1 lumpectomy, and some radiolucent stones were seen by CT scan, but no stone analysis was performed. And as when he arrived in our department, creatinine was 180 micromole per liter, the eGFR 37 milliliter per minute. Uric acid was 380 micromole per liter. He had a normal ionogram, and if you want to see the urines, pH is 6.5. Uric acid is 3.2 millimole per day, and he has a normal calciuria and normal oxaluria. So how should you make the diagnosis now? You have to vote.
Okay, so the voting is in progress.
So you have the choice between having a look at the urine density, looking back at the uric acid excretion, performing crystalluria, a stone analysis, or renal biopsy. You can choose several good answers, but
okay, Aude, I have the results of the voting for you. 63% of the attendees think we should do the stone analysis. 22% think you can do the diagnosis based on the uric acid excretion, 16% based on crystalluria, and we have no votes for renal biopsy or urine density.
Okay, so we will go further. My answer would be you should first perform crystalluria if it's available in your center, because this patient has no stone at the moment you see him. So you have not the possibility to perform a stone analysis. Of course, in the past, the urologist should have performed a stone analysis. But now we have the patient in front of you, and you can perform a crystalluria. If you perform the crystalluria, we'll see this round and reddish brown crystals with a very specific aspect here, or Maltese cross like this, using a polarized light. And this is really pathognomonic of 2.8 DHA crystals. So we are here in the family of PRT deficiency due to leading to 2.8 DHA crystals. This is in a kind of inborn error of metabolism. You know very well primary hyperoxaluria, but if you have a defect in purine metabolism, you can have uric acid or 2.8 DHA, like in this case, or very rare disease, xanthine expression with xanthine oxidase deficiency. And then you have also another rare disease, orotic aciduria. You have some other metabolic disease. You probably know already CYP24A1 deficiency. And you have then the family of all the renal tubular transport defects. We are not in the scope of this talk. So we'll have a better look at this disease. This patient has PRT deficiency. PRT is here an enzyme which is expressed in almost all tissues, and it provides the only pathway from the metabolic salvage of adenine, resulting then in the transformation of adenine in AMP. If you have a lack of functional PRT, adenine will be converted in 8-hydroxyadenine and then 2.8-deoxyadenine by the xanthine dehydrogenase here. And this DHA has a very high renal clearance. It involves both filtration and tubular secretion. And then this PRT deficiency will result in the very high urinary levels of DHA. It is extremely insoluble in the urine, and it will form some crystals. And then this crystal will gather, grow, and form stones. Or this crystal will precipitate in renal parenchyma and cause a crystalline nephropathy. This is a very rare disease. The prevalence is between 1 on 50,000 to 1 over 100,000 of patients, and less than 300 cases have been reported worldwide. This is a series published 10 years ago, which included in France 53 cases in 43 families. And the first information is that the median age at first stone is 12 years of age, but a very large distribution from neonates to patients more than 50 years of age. If you look at the age of diagnosis, the age of diagnosis is most of the time performed after 16 years of age. In 62% of patients, diagnosis will be performed after 16 years of age, and only in 38% of patients it will be performed in childhood, before 16 years of age. So there is median age at diagnosis, which is 36 years. So there is a very important delay between the time of first stone to diagnosis. The median is 1.5 years, but there are extreme to 43 years. And our patients had the first stone around 35 years of age, and the diagnosis was finally done 20 years later. How should we perform the diagnosis? So we spoke about crystalluria, which is very useful if available, but you also propose to perform a stone analysis, which is a very good mean to perform the diagnosis. In this series, 58% of patients had a stone analysis. And if you analyze the stone, you will have these reddish brown turning gray stones. They can be friable, and the composition will be confirmed by infrared spectroscopy. So if you have a stone, this is a very good possibility for diagnosis. In this series, some patients had diagnosis on renal biopsy, 11% of them, both native or transplant biopsy. We will speak about that a little bit later. And another way to have the diagnosis, as soon as you have suspected the diagnosis, is to analyze the APRT activity. It is interesting to note that 4% of these patients were initially asymptomatic. In very small children, the parents can have a look at the diaper stain, because there is a reddish brown diaper stain if the patient has 2.8 DHA crystals in the urines. What about renal biopsy? Of course, it was not the best way to perform the diagnosis in the patients we had, but this is another patient who were 64 years of age, and she presented with renal failure with no very interesting medical story. She only had one stone episode 33 years earlier. So she had a kidney biopsy, and we were very astonished to find this tubular interstitial injury with crystals. You can see the crystals by polarized light view or polarized microscopic view, and you can see all these numerous crystals. And on renal biopsy, you will be able to perform an infrared analysis to confirm the DHA nature of the crystals. So the clinical presentation may be very poor, I would say, with only one episode of stone many years ago. To go further in the diagnostic, APRT activity can be measured in erythrocytes, lysates. It is not mandatory to perform it, but it is useful if available. And there are two kinds of APRT deficiency, type 1, which is nearly all cases in non-Japanese patients, and the activity in this case is null in vitro, and type 2, which is 15 to 30% of normal activity, mainly found in Japanese patients. The urinary 2.8-D-hydroxyadenine excretion can also be measured, but unfortunately it's not available in many centers. It has been very well developed in Iceland. Several methods have been described, but more performant is ultra-performance liquid chromatography with electrospray-tended mass spectrometry, which will allow to measure the absolute urinary quantification of DHA. This method is 100% sensitivity and specificity for the diagnosis in patients not having any treatment. And you can see here that there is a very good correlation between the crystalluria and the DHA excretion. The patient having a very low crystalluria have a very low excretion, and the patient with is a high crystalluria have a higher excretion of DHA. Unfortunately, this method is not available in many centers. So the next step is to go to genetic. This is an autosomal recessive disease, and the APRT gene is located on chromosome 16. Mutant alleles in type 1 are called APRTQ0. There is a heterogeneous collection of mutations distributed along the coding sequence. And type 2 is caused by a single mutant allele, which is a missense mutation referred as APRTG. It is reported exclusively in Japanese population. And finally, 10% of mutations are not identified for the time being. What about the stone activity of this disease? 90% of patients have stones, but 10% have no stone episode before diagnosis. So in this patient, it's not a stone disease, it's more a crystalline nephropathy. Most of the patients have one or two episodes of stones, so it's not a very active stone disease. 1/4 of patients have 3 to 5 stone episodes, and some have more than 5 episodes. So many patients have no surgical procedures before diagnosis. 1/3 of patients had 1 or 2 surgical procedures, mainly shockwave lithotripsy or ureteroscopy. And some patients had more surgeries, including nephrectomy in one case. What about renal function? Because as you remember, our patients just presented with renal failure. In some cases, in this series, only one patient, but some cases can present with acute kidney failure. Many patients, 1/3 in this series, presented with chronic kidney disease, and some patients had already reached end-stage renal disease at diagnosis. 6 patients here. 4 were transplanted and 2 were already back to dialysis. And if we look at renal function at last follow-up of this patient, you can see that 40% of patients have CKD3 or more. So it's really a crystalline nephropathy, and it's a progressive kidney disease in some patients. As you can see here, the number of patients on end-stage renal disease increased at last follow-up, here in gray. But of course, some patients can be diagnosed early with a preserved renal function. But altogether, 20% of patients reach end-stage renal disease in this series. The age at end-stage renal disease is here in this other series from Iceland, around 40 years of age, but the patient can reach end-stage renal disease at a very different age. And in this series, 26% of the 53 patients reach end-stage renal disease. So it is a rare but very severe disease. What about children? There are 2 series, including some children. 19 patients with childhood onset PRT deficiency. So you can see that eGFR at diagnosis here was around 70, 80 milliliter per minute. But at last follow-up, eGFR was different in patients who initiated treatment in children or in adulthood. As you can see, the patients who started a treatment as a children had a better renal function, 114 milliliter per minute, compared to 62 milliliter per minute in patients who are diagnosed and with treatment only at adult age. And all the 3 patients in this series with CKD stage 3 to 5 at last follow-up were adults when the treatment was initiated. So if you can perform a diagnosis in childhood, the kidney function will be better preserved in adulthood. But how should we treat the patients? Tell me, please. This is your turn. So should we perform hyperdiuresis, alkalinization, allopurinol, troponin, or febuxostat? You can choose there again several good questions.
Okay, Aude, the voting is in progress. So we will wait for the final result.
Because you are very good, you have performed the diagnosis, so this is the first step, but now you should treat the patient.
Yeah, we have the final result. A little bit more than half of people suggest to treat the patient with allopurinol. About 30% of people suggest hyperdiuresis, 9% alkalinization, 6% theopronin, and 3% febuxostat. Okay, so let's go to see the answer. So first, theopronin is for another disease, cystinuria. So this is not the good disease. The first step in most of the stone disease is hyperdiuresis. It's always a good answer. More than 3 liters per day in adults. And the goal is to have density on morning urines below 1010. And you can ask the patients to have a look at the color of the urines, give the patient some color chart or some dipstick, having a look at the density. So it's very important. Hyperdiuresis is not very easy because it's a treatment that patients have to do every day, but it's very useful in all stone disease. Second step is to try to limit a little bit the purines intake. And then the pharmacological treatment is allopurinol, and maybe more recently, but more active, is febuxostat. Why? We can go back to our schema. You remember that this is a xanthine dehydrogenase, transforming adenine into 2.8 DHA. And you already know that hypoxanthine is transformed to xanthine and uric acid by xanthine dehydrogenase. And you already know that allopurinol is a very effective treatment for that, or febuxostat. So you will use the same treatment. You should use quite high dose of allopurinol, 200 to 300 milligrams per day. Sometimes it may be more, or febuxostat 5 to 10 milligrams per kilo. And then you will adjust the dose on crystalluria if available. The goal is to have a negative crystalluria, to have no more crystals in the urines. Of course, if you have 2.8 DHA measurement available, you could adjust on that. And alkalinization is not useful in this kind of disease. Alkalinization is very useful in cystinuria, in uric acid crystal disease, but it's not useful in this disease. And so our patients were treated with hyperdiuresis, allopurinol, and finally the creatinine improved a little bit and stabilized around 150 micromole per liter. But then everything was doing well, so he was lost to follow up for 2 years. And suddenly he had some lumbar surgical procedures, and he stopped allopurinol for the surgical procedures. And we were called because the creatinine had increased a lot, 823 micromole per liter.
as it was a very, there are no stones on CT scans, and we performed a kidney biopsy, and we found a crystalline nephropathy with there again some DHA crystal by infrared analysis. But the kidney was already fibrous, was interstitial fibrosis of 60%. So we treated the patient by hyperhydration. We went back to allopurinol, and we also used some steroids just for this crystalline nephropathy with inflammation just at the time of this event. And finally, the creatinine decreased a little bit to 340 micromole per liter. And 2 years later, he finally reached end-stage renal disease and had a kidney graft. What about the effect of the treatment on renal function? If you look at this study published by the Iceland team, you can see that the comparison between untreated in gray and treated patients. So on kidney stones, the treatment doesn't seem so efficient, but on CKD 325 and in particular end-stage renal disease, you can see that untreated patients have very frequently, in 92% of cases, some chronic kidney disease compared to only 25% of patients in treated patients. And renal replacement therapy is very rare, finally, in treated patients, but very frequent in patients without any treatment. And here you can see the effects of treatment on renal function by group age, by age, and you can see that eGFR decreased progressively, but there is a difference between the treated and non-treated patients. The slope, eGFR slope, is very low, 0.38 milliliter per minute per year in treated patients, but very rapid, 5 milliliter per minute per year in non-treated patients. So I think that you are convinced that now that on native kidney, it's very important to perform the diagnosis and to initiate a treatment, and of course not to stop the treatment. What about allograft? This is another series including only patients, transplant patients without any diagnosis before allograft. The age at end-stage renal disease was in this series 43 years of age, so it's comparable with the series from Iceland that we already saw. Most of the patients had only one transplant, but 2 patients already had lost one transplant, and it was their second transplant. Half of the patients have a clear history of nephrolithiasis. And if you look at the suspected cause of chronic kidney disease in these patients, only 2 patients had something like tuberointerstitial nephropathy or nephrolithiasis. 1 patient was considered as oxalate nephropathy, and 1 had nephrosclerosis, and 5 unknown. So the diagnosis was not performed in all these patients. But then, after transplantation, diagnosis was performed very quickly, median 5 weeks. And but the median between the first stone, if any, to diagnosis was 30 years. The diagnosis was performed some catastrophic situation in 9 patients, because this patient required already dialysis after kidney transplantation, and the other had already a severe chronic kidney disease on their new allograft. when the patient had the first event after transplantation, in 4 patients, the initial diagnosis was oxalate. 1 was urate, stone nephropathy. In 3 patients that didn't know, and only 1 patient had the good diagnosis initially after graft biopsy. And in 2 patients, finally, the diagnosis was performed on graft biopsy with the specific Maltese cross aspects. How finally the diagnosis was performed in crystalluria in 4 patients. In all patients, finally, infrared spectroscopy led to diagnosis. A PRT was performed in 7 patients, and it was null in all these patients, and 6 patients had genetic analysis. So the diagnosis can not have been done before kidney transplantation. So it's very important also that transplant specialists are aware of this disease. Of course, they usually have some oxalate nephropathy, but if it's not oxalate, they should think to this other diagnosis. And if you, once again, if you have the treatment, the diagnosis, you will treat the patients. The evolution of the patient was different from one patient to other, but some improved. In these patients, you can see that there was a very severe kidney disease with very high creatinine at the diagnosis. He received hyperdiuresis and xanthine oxidase inhibitors with a real good improvement of renal function. This is another example of patient with a very bad evolution of the disease. So all these patients were followed up for a median of 24 months. 1 was stable, 1 worsened, and most of the patients initially improved. And finally, creatinine last follow-up for the patient who was not on dialysis was 168 micromole per liter, which is not so bad. 2 patients lost their graft finally. 2 patients had normal graft function, and finally, the majority of the patients have chronic graft dysfunction. There again, what is the outcome according to the treatment? Of course, when you have relapse of the disease on kidney transplant, you have to perform the diagnosis and then the treatment. But in this recent publication, you can see that if the patient had a diagnosis before transplantation and was very well treated before transplantation, then the graft survival will be better. You can see here a group of treated patients compared to untreated patients. And in these patients treated at the time of transplantation, you have as you can think, a very good survival compared to the patient who had not a treatment. The 2-year allograft survival was 91% if well-treated patients, compared to 55% only in patients not transplant. So it's very important to treat the patient already at the time of transplantation. This is a kind of diagnosis algorithm for PRT deficiency proposed in the publication from Guillaume Bollet. You can see here if you have urolithiasis of unknown composition, first stone before adulthood. This is you should think to some kind of cause in these patients. Recurrent urolithiasis, radiolucent stones, which is not very usual, and decreased renal function. If you have a stone, go to stone analysis, as you suggested at the beginning of this talk. If you have no stone, then if it is variable, it's very good to perform a crystalluria. And if you have a decreased renal function with no proteinuria, no clear cause for the disease, and maybe a history of stones, but maybe only one, just perform a crystalluria study. It can be very useful. Of course, if you had no stone and you perform a renal biopsy, have a look at the crystals on renal biopsy. And if you have any stones or crystals on renal biopsy, go further for the analysis. And then maybe you will identify some 2.8 DHA. And then you will be able to measure the PRT activity, gene analysis, and start treatment. So 2.8 DHA crystalline nephropathy is very rare, but it is under-recognized. It's maybe a cause of chronic kidney disease, which can be dramatic, lead to renal failure, acute renal failure and stage renal disease, and recurrence in the renal allograft. The presence of crystals in the renal parenchyma or in the urine should not be overlooked. You have to go further if you detect any crystals. And then if you have the diagnosis, start inhibition of xanthine dehydrogenase. Probably fexusostat is a little bit superior to allopurinol. It has been shown in one study with very few patients, but this is one point. So have the diagnosis and then you will have the treatment. Thank you very much for your attention.
Okay, thank you very much, Aude, for this, I think, very comprehensive overview of HPRT or APRT, sorry, deficiency. I'm looking for the question box here, so I would again like to welcome everybody to put their questions in. And actually, the winner of the first question award is Eliza Ferrari, who put in the question whether there is any deposit in other organs that could help raise the suspicion of this diagnosis. So is it renal limited or is it also somewhere else?
No, it's really renal limited. So yeah, it's not the same that other crystalline nephropathy. In this case, it's really only limited to the kidneys. So you have not other organs that can help for the diagnosis.
And a little bit along that lines, that line, of course, you said that the prevalence is 1 in 50,000 and 1 in 100,000. Probably we don't know exactly, right? Since it's under-recognized.
Yes, probably this patient with chronic kidney disease, maybe some are not diagnosed.
Mm-hmm. And do we know anything, because we are now more and more also sequencing patients with CKD of unknown cause, especially when they're younger. Do we know how often we find this deficiency just primarily via these genetic screening panels?
Yeah, this is a very good question. I'm not so sure that it is on all panels that use for the chronic kidney disease patients. I think in a very large series, I saw one or two patients, but I have not a good number for all these series. I'm not sure it is included in all panels, but it should be. Of course, this is a good way to have the diagnosis.
One of the questions in the question box is, if we can't perform genetic testing, what test can we do to diagnose? So I guess to ultimately, let's say, diagnose or how do you say, confirm the diagnosis?
So if you have not genetic testing, this crystalluria, if available, it's very good for all the stone disease. The stone analysis, if the patient had any stone, you have to go to stone analysis. And if not, you can measure the APRT activity. This is quite available.
And I think that what I also took from your presentation is that also if you have let's say a urine without proteinuria, without erythrocyte, without leukocytes, then it still can be informative to look at the urine, because these crystals might be there, right?
Yes. I think in all these patients with no diagnosis for renal failure, with no very easy cause, having a look at the urines is very useful. And of course, if you perform a kidney biopsy, have a careful look if there is any crystals. And if you find any crystals, you should go further for the analysis of the crystals.
Yeah. Somebody else is asking, do these patients have, it's a little bit along the lines of the first question, do these patients have other symptoms because of the disturbance of adenosine? Maybe endocrinological problems?
No, it has not been described, and it's not what we observed. No, it's really a stone disease with a kidney recurrent on the transplant, but no endocrine, and I'm not so sure that the bone has been very well analyzed in these patients, but we have no data on that.
Yeah. And with respect to treatment, there are also questions or maybe suggestions coming in, whether there is any role for liver transplantation or stem cell transplantation in these patients.
So the enzyme is present in all the organs. Liver transplantation, as soon as you have a good treatment with allopurinol and febuxostat, and if you don't stop it, so as you have seen, the prognosis is quite good. So liver transplantation has not been proposed in these patients. It's not the same that hyperoxaluria and other disease. We have a good medical treatment, so stem cell, why not? But it has not been proposed for the time being, and we have quite simple treatment because all the studies, even if they don't include many patients, show that if you have the patient that is well treated with quite simple treatment, the prognosis is quite good. So maybe easier than liver transplant.
Yeah, yeah. And when you're successful with that, the next question is, what do you advise for follow-up for a patient which has a normal kidney function, negative crystalluria under allopurinol treatment?
So you have to perform a regular assessment of urine density. Once again, if available, crystalluria, and it's important to follow the patients because at any time, if the motivation is decreased, if the patients stop having hyperdiuresis, drinking a lot of water, in any event, the patient can have acute renal failure. So it's very important to follow the patients every 6 months or every year, and to also help the patient to be motivated to continue the treatment. But if everything is fine, just have a look at the urines and some ultrasound once a year.
And if there is acute renal failure, what do you think that the pathogenesis of this is? Because apparently, upon treatment, you can also reduce it again. So is that then obstruction, or is that really an intrarenal problem because of the nephropathy?
Yeah, it's not only an obstruction, because in some patients you have not a stone, an obstructive stone. It's quite some crystals in precipitation in the tubular in the tubules, and then in the patient which had a kidney biopsy, there is some inflammatory pattern around the tubules. So there is a kind of probably initial obstruction and then inflammation in the kidney. So it's not only obstruction. That's why in some cases steroids, for a very short period of steroids, can be proposed just to treat this inflammatory pattern.
Okay, okay, that's good to know. And I was also wondering, but I guess you already said something about that, whether you could see and follow this with, for instance, ultrasound. So can you see the crystalline nephropathy also on ultrasound, and can you then also see that it gets better upon treatment?
No, the problem is that you can see the stones, but this patient has not so many stones. So by ultrasound or CT scan, which is maybe sometimes better, you can see only the stones or the small stones, but the crystalline nephropathy cannot be seen by any ultrasound. So then this is only the crystalluria and the urine analysis or the follow-up of the kidney function which can help this crystalline nephropathy. Or kidney biopsy, but of course you will not perform a kidney biopsy very often.
Yeah, with that respect, I was also intrigued by the fact that after transplantation, the diagnosis is made very fast, actually, especially if you compare it to before transplantation. Does that also have something to do with the fact that we easily do biopsies there, and that then the biopsy gives you the diagnosis?
I think so. I think after kidney transplantation, there is a period with a very strict follow-up of the patients. So as soon as there is an increase of creatinine, some exams will be performed, and if all these exams are negative, a kidney biopsy will be performed. And then in most of the cases, if you think to the diagnosis, you will have the diagnosis. So I think it's a very strict follow-up, and then a kidney biopsy, and then finally it will lead to the crystalline nephropathy and then the right diagnosis.
Yeah. I see another very practical question in the question box, which is there an absolute maximum dose of allopurinol you would give these patients per day?
Usually the dose, maximum dose in adults is 300 milligram per day. In some publications, some patients received more to 600 milligram per day, but the recommended dose is more 300 milligram per day. And febuxostat is probably more effective. In the recent study from Iceland, the patients with really negative crystalluria were all on febuxostat. So maybe it's a little bit better treatment. So if you have the feeling that the treatment is not completely effective, you should maybe switch allopurinol to febuxostat. And I will not go to very high dose because you have also the toxicity of these treatments.
And with respect to inheritance patterns, so it's autosomal recessive, right? Is there anything known about the heterozygous family members? Do they also have a bit higher chances of stone disease or of kidney disease? Or
they are supposed to be asymptomatic, but there are not so good studies of all the family members, but they are supposed to be completely asymptomatic.
Okay. Okay, I don't see any new questions coming into the question box anymore. So I guess I would like to thank you again, Aude, for the very comprehensive presentation on this on this topic. And I would like to thank everybody for attending this webinar. And also please mark your calendar for the next webinar, which I think is in 2 weeks, but I lost the overview here. Oh, you have a slide, which is very nice. So indeed, in 2 weeks, there's the webinar on glycogen storage diseases by Francesco Trapacioni from Naples. And in April, we will have another webinar on disorders of renal calcium handling by Pascal Rouillet from Paris again. And in May, we will have the webinar on syndromic ciliopathies, especially Bardet-Biedl by Jens Koenig and Helen Dolphus. But mark your calendar at least for the next one, 21st of March, glycogen storage diseases. Okay, thank you all very much, and hopefully we will see you at the next webinar.
Bye.
Thank you. Bye-bye.